Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Podcast will focus on immunoglobulin A nephropathy. We're joined by Dr. Richard Lafayette. Would you like to introduce yourself?
Sure, I'm happy to be here. I'm Rich Lafayette. I'm a professor of medicine at Stanford University Medical Center, and I run our glomerular disease clinic and center, and have lots of experience taking care of patients as best we can with IgA nephropathy.
Would you like to introduce yourself?
Hello, my name is Carla Nestor. I'm a professor of pediatrics at the University of Iowa. My clinical practice actually is in the glomerular diseases, and I have a special interest in the complement-mediated glomerular diseases.
And Dr. J. Radhakrishnan, would you like to introduce yourself?
My name is J. Radhakrishnan. I'm a professor of medicine at Columbia University in New York, and I'm part of an enterprise called the Glomerular Center, where we focus on glomerular diseases, both research, clinical care, as well as education.
Our topic will be the overall impact of IgA nephropathy on quality of life. Dr. Nestor, if we could start with you. I imagine that it's safe to say that IgA nephropathy adversely affects quality of life. Can you talk a little bit about how it affects different aspects of quality of life in your patients?
IgA nephropathy, as the most common glomerular disease in the world, affects, I think, quality of life in a lot of different ways. These patients are often very inflamed, I'll say. So that means that they often feel significant fatigue. Some patients may even have some actual pain from their disease. But I think that these combined physical symptoms actually translate very frequently, actually even into some psychological symptoms. And the patients will very frequently worry about, where is my disease going? How are we going to treat it? How successful are our treatments going to be?
And how about do your patients ever express any concerns about the economic burden or maybe caregivers?
Yeah, I think that, the economic burden obviously is that IgA, like the other glomerular diseases, requires regular doctor visits, regular missing of work to actually get to the doctor visits. And very frequently, for instance, in pediatrics, that means the caregiver is also going to doctor visits. So I think that certainly not only do you have that physical symptom component, but you also have the component of worrying about, how many more visits do I need this year? Have I met my deductible, et cetera? There's many of those financial aspects that I'm sure plague many of the patients and their families.
Dr. Radhakrishnan, when a patient comes to you, how would you assess their quality of life clinically, and who would be responsible for doing that?
Right. So during the conversation with patients, it becomes quite manifest that patients are coming with a chronic disease that is likely lifelong. So we always gently probe as to how are you dealing with the disease. Do you have any concerns about aspects other than medicine? Is it affecting your work, your home life, your family life? So we always look into this, and as treatments evolve, I think it's very important that patients need to be assessed, not only for the medical aspects of IgA nephropathy, but also the psychological and economic aspects.
And do you notice any differences in things like how age or race, disease severity, different parameters affect quality of life?
Yeah, truly. So unfortunately, IgA nephropathy is a disease of young people, and it affects people in the prime of their productive lives. And when you're faced with a lifelong chronic disease, there's frequently stress. And although in the early stages, there's not much of a physical manifestation, but as disease progresses, people do experience progressive IgA nephropathy over the next, decade or two after diagnosis, then the symptom burden with chronic kidney disease becomes manifest. And that essentially is a phase that we really need to acknowledge and say that, look, it's not just checking your creatinine and blood pressure. But there are many, many other aspects of this disease that we need to be holistic about.
Dr. Nestor, what about treatments? Can you talk about how you see treatments change the quality of life?
First, I would like to actually mention about this being a chronic kidney disease. It occurred to me when you think about a chronic kidney disease in children or young adults like IgA does classically affect, one of the things that is actually probably worth mentioning too is the fact that they don't feel like their classmates. They don't act, they often can't keep up with their classmates. And I think that that actually ends up being a significant stressor to them also. But now if I also think about treatments, unfortunately, historically, we've used a lot of treatments that they can work and they have worked in some patients, but they also have significant side effects. For instance, most patients will tolerate blood pressure control with ACE inhibitors, et cetera. But when we get to the point of adding things like steroids, many patients will have adverse effects to the use of steroids. But unfortunately, it is a commonly used approach to IgA nephropathy patients. So imagine patients, regardless of what their age is, the side effects can be significant.
Dr. Radhakrishnan, when you finally get things under control, is there an apparent improvement that you see in your patients?
So if you look at the CureGN quality of life study, the biggest item that had strongly associated with quality of life was edema. So when patients have progressive CKD, edema becomes important. And this is not just for IgA, but any glomerular disease. So controlling edema, controlling fatigue with supportive care becomes very important, not just focusing on the IgA, but the other aspects of IgA, which is chronic kidney disease, as Dr. Nestor was saying. Now, once we gain control of the disease with modern therapies and patients experience a reduction of proteinuria, there's an immediate improvement in how patients feel. And I think that should be the goal. It's not just the biomarker improvement, but in the quality of life improvement, which is equally important when we consider managing these patients holistically.
So we'll move to the next topic, and our topic will be research roundup. And this topic really is about some of the more recent research that's come out regarding IgA nephropathy and treatment. Dr. Radhakrishnan, there seems to have been a rapid advancement in the development of new treatments for IgA nephropathy. Can you talk about why that might be and maybe some of the recent treatment targets?
Yeah, I should say that this phrase is often used, from famine to feast. And I think for the last 4 decades, we were struggling with only corticosteroids being the real treatment for IgA nephropathy. And we have come to a situation where we have now 3 FDA-approved therapies that we can use in our patients. And many more are in the pipeline, and especially the excitement is around targeted therapies, looking at various aspects of the pathogenic pathway that leads to IgA nephropathy. So my sort of concern, and this is kind of crazy, is that we will have too many therapies, and it'll be difficult to choose which therapy is appropriate for a given patient.
We finally have regulatory acceptance of proteinuria as being a legitimate target. And so, like what's been said, that opened actually the door to being able to trial a number of new things, because now we have a biomarker, if you will, that the regulatory agencies will accept as if you improve that biomarker with a given therapeutic, then you potentially improve the disease. So I think that that's an exciting time. That's something that's not present in a lot of our glomerular diseases, frankly. So it's an exciting time for IgA nephropathy patients.
Yeah, so, previously hard endpoints would be a doubling of creatinine, 40% drop in GFR, or when patients reach end-stage kidney disease, death, dialysis, or transplant. And these would take an awfully long time for a disease like IgA nephropathy. So essentially, you're designed to fail if you use hard endpoints. So the FDA, in its wisdom, used proteinuria as a surrogate endpoint, which led to conditional approval. So that would lead to rapid approval of a drug. And then the second aspect of approval would be something called the eGFR slope. And you don't need a big change in the eGFR slope to predict downstream hard endpoints. So the combination of the proteinuria for conditional approval and the eGFR slope for final approval has led to a dramatic change in the rate of approval for novel therapies.
And so agents which address trying to reduce galactose-deficient IgA, try to reduce inflammation and responses to galactose-deficient IgA to reduce antibodies, anti-inflammatory therapies like old ones like steroids and mycophenolate, and new ones like B-cell modifying drugs and anti-complement agents were rapidly tested. And again, now in 2024, we've got multiple approaches that are looking at these different targets and more specific for our patients and for the disease IgA nephropathy.
What are some of those more recent targets or trials that we should be watching?
Well, there are really quite a number of them. Again, for fully approved drugs, we now have targeted budesonide or Nefecon, and Nefecon's fully approved because it was demonstrated it could reduce proteinuria and does on average, and slows kidney disease progression with just over 9-month treatment. And this drug was designed, just as I mentioned, we know that at mucosal surfaces, IgA is created to fight infections there. So this drug targets the distal small bowel and tries to give anti-inflammatory there in the form of a steroid. But this steroid's not well absorbed into the circulation and therefore doesn't give a lot of systemic steroid side effects. So you can reduce galactose-deficient IgA, stop this 4 hits from propagating, and reduce proteinuria, hematuria, and kidney disease dysfunction. So there it targets upstream events. We have another drug called sparsentan, which is an endothelin receptor antagonist, and that was designed to join angiotensin II receptor blockers. The sparsentan actually has angiotensin receptor blocking activity itself and endothelin receptor blocking, so that it can lower the blood pressure a little bit, lower the strain on the kidney, and likely block some of the inflammatory and harmful effects on kidney-specific cells. So this dual endothelin angiotensin receptor antagonist has been proven also to lower proteinuria, protect the kidney, and is also now fully approved for treating patients with IgA nephropathy. And just recently, an anti-inflammatory approach looking to quiet down the kidney response with complement has also been approved in accelerated fashion for patients at high risk for progression, and that blocks complement factor B, an important part of the alternate complement pathway. And this drug, iptacopan, is available now for use in our patients. So you can see we can really start targeting, as I said, with Nefecon, upstream events, with sparsentan, downstream kidney-related issues, and the inflammation that's specific to the complement pathway with iptacopan. And right on the horizon are more agents looking to target galactose-deficient IgA and the autoantibodies, the B-cell modifying drugs, and we have multiple more complement inhibitors in the pathway as well.
Yeah, I think that first of all, I will say that again, exciting time in the glomerular disease world that we're even having these agents being approved for a very specific glomerular disease. So I think that has 2 effects. First of all, it gives the clinician confidence that the treatment approach can be more than just simply blood pressure control. Blood pressure control is very important, obviously, but it can be more than simply blood pressure control and application of steroids to this group of patients. So that gives, I think, that the clinician some confidence that these newer agents are going to allow the potential for some steroid sparing, if I can say. So maybe these newer agents will actually allow us to be able to use shorter courses of steroids. That's one thing. But also, I think, frankly, for the patients, it also gives a good deal of confidence that we're making progress in a field that as was mentioned earlier, for 4 decades, we weren't really making the progress that would suggest that we're beginning to target the very specific parts of the disease process.
How about any investigational treatments or combination studies that are under investigation?
Yeah, so I think the landscape's going to change dramatically, 5 years from now. So we've already have three medications, as was mentioned. And the question is, can we use those medications in combination? And the answer is absolutely, right? So if you were to take the various so-called hits in the pathogenic pathway, we can easily combine a medication that reduces the production, for example, of gal-deficient IgA with a medication like budesonide, which is essentially acting on the gut to reduce the production of antibodies. And in the same patient, if there's really aggressive IgA nephropathy, instead of using steroids, you can combine this with a complement inhibitor. And then in the same patients, if the patient has sort of progressive, signs of fibrosis on the biopsy, for example, you may add an endothelin antagonist. So this is very similar to cancer therapies, that one sort of drug may not hit all the targets. And obviously there's a issue of expense, but we need to give our young patients the best chance at controlling the disease early on. But because with every passing year and decade that the disease is not controlled, the chance of hitting end-stage kidney disease goes higher and higher. So we don't know what the landscape is in the future, but we have a lot of targets to hit with a variety of drugs.
Well, with that, I'd like to thank our experts for sharing your insights with us today. And thanks to our audience for tuning in. We hope that this podcast will be valuable for you and the way you treat your patients. And we look forward to having you join us next time.